Good morning, everyone. This morning, the Anne Arundel County Council is meeting in special work session in order to receive an update on the vaccination rollout from our officer, Dr. Nirlesh Kalyan-Raman. After a presentation, which is going to we will take questions from the council, and we're scheduled to run from 10 to 11:30 in the morning. So hopefully everyone will be able to get their questions asked in that time frame. And if not, we'll see how it goes. Dr. K? Oh, wait, before I call Dr. K, Madam Secretary, would you please?
Ms. Hare?
Present.
Ms. Pickard?
Present.
Mr. Volpe?
Present.
Mr. Pruski, I do not believe is here. Ms. Fiedler? Not here yet. Ms. Rodvian? Not here yet. And Ms. Lacey?
Present.
Okay, Madam Chair, we have Ms. Hare, Ms. Pickard, Mr. Volpe, and Ms. Lacey currently in attendance. I believe Ms. Fiedler and Ms. Rodvian will be joining in a little bit.
Excellent. Dr. Kalyan-Raman, are you ready to proceed?
I am, and thank you.
Good morning.
Good morning. I will, 1 second, and I will share my screen and we'll be on our way. All right. So I provided these slides earlier. It has the beginning portion has some data and information in a format that you've seen before on where we are with COVID. I'm going to move through that extremely quickly so that we can focus on vaccines, but I did want to include that for completeness. And I'm happy to obviously focus on any area that you would like. Now we start off with our principles of limiting the virus to keep people healthy, allow schools to open and keep businesses open. Our case rate, as you well know, is in the 60s, 63 a couple of days ago when we made this slide. Obviously a very high case rate, and you see the trajectory is still up. We are a couple of weeks now past the holidays, so we're looking to see what happens, whether that curve starts to flatten out, and it looks like it is at least not moving as quickly upwards as it was a few days ago. But most concerningly is our hospitalization rates will continue to go up, and they will continue to go up as for at least a few weeks lagging our case rate. Our hospital capacities are in the mid 80s, and we know that our hospitals have had to make changes, including increasing capacity and also delaying time-sensitive procedures to be able to handle this increased COVID volume. And this is a graph of where the hospitalizations are in Maryland as total. As you can see, it is a new high and is on the upward trend at this point after flattening out for a period of time. Percent positive is 10 to 11%, much higher than our 5% target. And I'm including this, which is seroprevalence, which is an estimate of what percentage of people are positive, have had COVID. This does not come from us or the Maryland. This comes from CDC data that estimates seroprevalence, or how many people have had the disease to date. And their estimate is that about 10% of the Maryland population has had it based on antibody testing. This just gives you a rough sense of how many people have had it since the beginning of the pandemic over 10 months ago. I did want to touch on the new COVID variants, particularly the B117 variant, which is every virus has strains or variants. COVID has many strains or variants. We really haven't talked about them because they don't really seem to cause any differences in how either easily it's transmitted or any severity of illness or death. except for these two variants. So the B.1.1.7 variant, which was first identified in the United Kingdom, does transmit more easily, somewhere in the order of 50% greater transmissibility. It does not cause more severe illness or more death, but because it moves so fast, more people are getting sick at the same time, which leads to more people dying simply because there's more people infected, overwhelming hospitals faster. In Anne Arundel County, we've had 2 cases confirmed. The first 2 cases with in Maryland with folks who have the B.1.1.7 variant, and we're working with the Maryland Department of Health on contact tracing extensively in that group to identify if any others have that strain. A number of other states have identified B.1.1.7 in their states, and we anticipate, based on what's happened in other countries, that it will continue to spread, precisely because that is why we are paying attention to it. It is a rapidly spreading variant. Another variant, B.1.351, we haven't talked much about because we haven't really detected it in the United States yet, but it is something to be aware of on the longer term horizon. It too spreads more quickly. Current thought is that vaccine is just as effective against these variants, all the more reason that we want to continue vaccinating and continue our precautions. Our infection rate is still above 1. As we talked about before, we do want that to be under 1 so it can shrink. As a consequence of these rising case rates and hospitalizations, we see that our deaths are hitting levels that we had not seen subsequent to the spring. So this is what the spring was like when we were had a stay-at-home order, and now we're seeing about 20 deaths a week, so about 3 a day. And we expect that to continue for a period of time because that too is going to lag hospitalizations. This is just a summary of what I talked about, and a summary of our hospitalization trends and our projections. We talked about our projections of overwhelming our hospitals. Our capacity statewide is about 8,000 beds, and typical occupancy is around 6,000 beds. Our projections starting in November, we're showing over 12,000 people with COVID alone, separate from anybody else. And that's why we began our push really strong in November, talking about the fall surge and really pushing that down. Our projections are at for the state are max 3,500 to 4,000 COVID hospitalizations, which would still be over capacity for our system, but they are able to manage through capacity expansion. I talked about adding beds and staffing is really the biggest barrier, and also delaying some time-sensitive procedures. Those do come with costs, but at this level of projection, that's actually executable in a way that we couldn't have handled the volume we were talking about or projecting in November. So that's the quick version. And I wanted to pivot to vaccines and really focus on that. So the first thing is, how does this vaccine work? This is a new type of vaccine that we really don't use in the public. It's in any of our vaccines that are publicly given. It's an mRNA vaccine, and so that means it's a set of instructions to your body to make the spike protein. Everybody has seen the picture now, the coronavirus vaccine, that little red knob that's all over the virus. That's the spike protein. That's how it attaches to your cell. Most other vaccines contain a part of the virus or the whole virus. This is different. It contains the set of instructions on how to make that part of the virus. It gets into your body through the injection, and then your cells make that protein that the virus has, and then your body says, hey, that's foreign, develops antibodies to it, and then critically, that mRNA instruction is destroyed by the cell. I like to think of it as like the IKEA instructions. None of you can find your IKEA instructions anymore, right? You get it, you use it once, you toss it out, now you have your bookcase. That's what an mRNA vaccine is. It's the IKEA instructions. So we have 2 approved COVID vaccines, the Pfizer and the Moderna vaccines. Both are given as 2 shots, and these were approved just a month ago. Now, we are just coming up on the, I think this is the 1-month anniversary of Pfizer. So the Pfizer gets a second shot 3 weeks later. The Moderna is a shot 4 weeks later. They also have different handling instructions. The Pfizer has to be held at ultra cold temperatures, -80 degrees Celsius. Moderna can be handled at regular freezer temperatures. Critically, the first shot gives you a partial effect, and the second shot gives you the full benefit of the vaccine. And both of these vaccines were in trials. Both doses were part of the trial. I know there's been discussion about giving 1 dose or 2 doses. We are giving 2 doses. That is what is recommended. That gives the full benefit. So these are both approved by the FDA under an emergency use authorization. There's 95% efficacy for both approved vaccines. That means that people who get it are 95% less likely to either manifest symptoms or severity of symptoms, which is pretty spectacular for a vaccine like this. For comparison, flu vaccine efficacy is somewhere in the 40 to 60% range, depending on the year and the strains. So this is an extremely effective vaccine. The process was rigorous. I know there's a lot of discussion about how you get a vaccine in 1 year. It was a very rigorous process, greater transparency, and I think critically significant minority enrollment for both vaccine trials, much more than is typically seen in vaccine trials. 9% African American, 20 to 26% Hispanic, and these are United States enrollment trial data. There are side effects. They are common, but they're fairly easily manageable. Headache, fatigue, chills, and there are more side effects with the second dose. There's some serious side effects, and particularly anaphylaxis is the one, and it seems to happen most commonly in people who have a prior history of anaphylaxis. I can tell you that at the health department, we elicit that, and the typical monitoring is 15 minutes, and if somebody has a history of anaphylaxis, we'll monitor 30 minutes. So there are ways to adjust your monitoring based on somebody's past medical history. In terms of vaccine development, it's built on decades of research on coronaviruses, of which COVID is just one member. So many common colds and flus are coronaviruses, but so are SARS and MERS, if you remember them from the beginning of 2000 and the beginning of 2010s. And so, vaccine research on coronaviruses have been happening for decades. Same thing for mRNA vaccines. That kind of research has been happening for decades. And really those two threads came together with a massive global coordination of efforts and money because everybody was paying attention to COVID. And that meant that unlike other vaccine trials where it's just one piece of everybody's attention, COVID vaccines was the entire piece of everybody's attention. And so with that broad recruitment into vaccine trials, that's how we were able to get a vaccine that was developed and deployed 1 year after discovery of a virus. We've never seen a timeline like that, but it was built on decades of work. So who's going to get the vaccine? We are currently in phase 1A, and just a note about our phases, we are building our phases based entirely on the CDC and the Maryland Department of Health. So initially we were following the CDC, and once the Maryland Department of Health came out with their guidance, we adjusted our phases to be in line with that. Our phases are, right now we're in 1A. I started with healthcare workers, public health, nursing homes, first responders, judiciary, and corrections. Starting Monday, we'll be expanding, and we're expanding. We were prepared to expand even prior to the governor's announcement because what we were finding is we were spending more and more time trying to get healthcare workers into those clinics. We were filling our clinics, but if it was taking that much time, we wanted to start infusing more people into the vaccine pipeline so that we can just get people vaccinated and not spend our time hunting people down. So we are starting with age 75, starting next week. Assisted living facilities and group homes, those are being done by CVS Walgreens through a federal contract. Homeless shelters, we at the health department are doing those, and then senior housing, we'll be having discussions with the aging and the housing authorities in the county and city to discuss how to get that done. Additionally, in phase 1B, school teachers and staff, both public and private, and childcare. And we have, and I'll talk more about this, we've partnered with the fire department to do first responders, and we'll be partnering with them to take care of the school teachers and staff to vaccinate them as well. Phase 1C is the next phase. We anticipate it's got two pieces to it. One is an age-based, and so age 65 to 74. The governor announced that counties could enter phase 1C for this age group starting January 25th. We're going to need to see what our demand is for our 75-year-old and up age group before we make a decision on when to open up to 65-year-olds. And the base reason for that is that as you go higher in age, your risk of death just climbs. And so we want to get those at the highest risk. So people over 75, we want to get as many of them done as possible before we open up the 65 to 74. And then once we get through the bulk of phase 1B, we'll pivot to opening up to the frontline essential workers, food, agricultural, and that refers to manufacturing and agriculture for food, U.S. Postal Service, manufacturing, grocery store, and public transit. The idea behind this group is these are a set of workers who have not been able to either do work remotely or decrease hours. They have been critical to the infrastructure of society. In some cases, public facing, in some cases, working with other coworkers, but there's no such thing as taking a moment off. After that is phase 2. It has one age-based group, age 16 to 64 with high-risk conditions, and there's a rather extensive list of what comprises high-risk conditions that the CDC has shared out, and that's available on our website. And then also essential workers. So I'm not going to read the whole list to you, but it includes sectors from across society who are critical to our operations, but at a slightly lower risk level than the frontline essential workers. I think our big challenge is that not every profession and sector is well represented in this list, and so we're working through how to classify those types of groups based on using the ethical framework put forward by the CDC, by the Advisory Committee on Immunization Practices. We try to match a couple of things. One, what sector are you most similar to? And two, what is your public facing exposure? And then lastly is phase 3, which is age 16 to 64. So pretty much everybody for whom this is approved. You'll notice that children age 15 and younger are not represented here, and that's because no vaccine has been yet approved for them. We anticipate that there will be more news about that in summer or fall as to a vaccine for children. But until then, we don't really have a phase for them unless we have that. These dates are all tentative. They're based on vaccine supply. They're based on expectations of what we'll get from the state and from the federal government. We'll see what happens. There's talk in the new administration of increasing vaccine supply of what's already existing. We just don't know at this point how that vaccine supply might change. So if we're able to move these phases earlier, we will. If we're not and we have to delay them because there's less vaccine, we will have to do that too. So these will be adjusted on an ongoing basis. I want to bring up 2 points. Honor system. We're finding a small but significant number of people trying to jump the line. That makes it hard on our staff. That makes it on our staff who are faced with the decision of, do I want to turn somebody away or do I allow that? And then more people come in and jump the line and push aside others who are in that phase. So we're asking people to just stay within your phase. I know it's hard. I know that a lot of folks want it, but please just recognize the risk, because the prioritization is based on a couple of factors, as you've noticed. One is individual risk. What is any given individual's risk? And a lot of that is based on age. Some of that is based on chronic health. And then the other is who is essential for societal functioning. And I know that everybody may not agree with how these categories were actually developed and who is in which category. But I think working off a set of national and state standards allows us to be at least more uniform in how we do this work. And that's what we are doing. So to talk very specifically about what's happening in the state and what's happening in the county, The state gets approximately 70,000 vaccines a week. That's the current federal allocation. And we at the health department get about 5,000 of those vaccines a week. The remaining allocation of vaccines to the county goes to pharmacy partners to vaccinate nursing homes and assisted living facilities, to hospitals, the 2 hospitals. Starting next week, commercial pharmacies and specifically Giant is going to get vaccines. And then federally qualified health centers, Big Community, Total Healthcare, and Chase Brexton will be getting vaccine as well. It's minimal right now, and we don't really know the allocation yet. That is being determined at the state level. So we don't control the amount of vaccine that goes to any of the other partners in the county. That is controlled at the state level. Right now, we get enough vaccine supply to vaccinate 1 to 1.25% of the population each week. At current supply levels, if you do the math, that works out to only about 50 to 60% of the population by the end of the year. And that's why it's going so slowly. Really, we need increased production and new vaccine approval to increase the pace of vaccination. This is just a breakdown of the percentages of vaccine that have come to that Maryland state has done. It's not specific to our county, it's specific to the state. You can see that 58% have gone to hospitals. Only 25% of total vaccine allotment has gone to the local health departments. And then 13% to the 2 national pharmacies for nursing homes. So our capacity in the health department, we can provide 5,000 first dose vaccinations each week. And we're adding staffing to provide an additional 5,000 second dose vaccinations because those are coming due starting next week. So we'll have the total capacity to do by February 10,000 vaccinations a week between first and second doses, and that's in line with our allotment at the present time. We receive our vaccine supply midweek, anywhere between Tuesday to Thursday is what we understand at this time. And once we get that, we can open slots for the following week to use up that supply. Until that becomes more standardized, both the day of delivery and the amount of delivery, it's really not possible for us to plan more than 1 week in advance for vaccine slots. And we are using the full supply provided each week by the end of the following week. So once we get that supply, we know how many slots to open up. We open it up next week and we use it all up. And we are on track to use it all up and then some by the end of today, what we got last week. We're right now, locations of partners, we are partnering with the Arundel Medical Center, Baltimore Washington Medical Center. They have been getting vaccine. They got a vaccine amount that totals their entire staff. They don't have uptake by their entire staff. And so they're going to start vaccinating healthcare workers from the community over the next few days. And then we're talking to them about how they expand their vaccination efforts beyond the phase 1B. Federally qualified health interns, I mentioned, Giant Pharmacy, I mentioned. Fire department has been a really key partner. They've done the first responders and they will be doing the schools. And then CVS and Walgreens will continue with the nursing homes, assisted living, and group homes. Our health department sites, we are vaccinating at the community college, Bay Meadow. We're opening up at Maryland Live in Hanover on Monday. We are planning and looking to launch the Naval Academy Stadium site, hopefully by the end of the month. Just working out all the details on that. And then a mobile clinic, very much in the spirit of what we did with our pop-up testing. We'll have a mobile clinic as well. We focus very much on doing high volume vaccine delivery in our first few sites. Once we get them set, we will work on adding additional sites throughout the county to provide greater geographic distribution, probably smaller volumes at those sites. In terms of staffing, we're using existing staff. We have not gotten any additional monies to actually do this vaccination effort. And so we're pulling existing school health and disease prevention staff to do this effort. I can tell you that our staff is stretched about as thin as it can go at this point. There's nothing left. We are looking to hire 120 new staff for all facets of this effort. Those job positions are out right now. Nurses, vaccinators, and support staff. We requested some National Guard support, and I believe they are there today for the first time. I think it's about 7 to 8 people. every little bit helps. I mentioned our partnership with Anne Arundel County Fire Department, and we're also partnering with the Department of Aging to reach seniors, both in terms of communication and in terms of vaccinating homebound seniors and looking at other populations that are more vulnerable in the older age range. And we're exploring other partnerships actively throughout the county and beyond. So we're getting a lot of questions about how to get your shot. We're currently sending appointment invites directly to groups in phase 1A. We asked healthcare workers to sign up on our website because we don't have lists of who all the providers are in all the various professions. As we move into phase 1B, we're going to be starting online and phone pre-registration for every county resident and worker. So that means no matter who you are, you can pre-register. As soon as you do it, it'll tell you what phase you're in, when we expect to get you, but much more importantly, it'll allow us to contact you when it's your phase to get a vaccine and to give you a link to our appointment registration, which is called PrepMod. That's the state platform being used to do vaccine appointments. So I just want to emphasize it's a two-step. One is pre-registration, so we have your name, we have your email, because we can't vaccinate everybody now. And when it's your phase, we can reach out directly to you to give you slots for appointments so that you can sign up for an appointment. So that pre-registration will go live next week. And then we have our dashboard, which is up. This is data from yesterday morning, so it's a bit out of date already, but it'll share with everybody current phase, how many residents have been vaccinated, and then how many we are doing at the Department of Health. As we go along, that number from the Department of Health will be a smaller and smaller fraction of the total vaccinations done in the county as we have more partners doing this work. And that is it for that. And I'm happy to take your questions.
Ms. Hare.
Thank you very much, Madam Chair. Jessica Hare, District 7. I have a few questions, so if anybody else has a yellow flag, I'll just ask one or so at a time. I'm trying to understand when we got the first allotment in terms of how many people the Anne Arundel County Department of Health has vaccinated, because I will say anecdotally, we're hearing it's very slow compared to other neighboring jurisdictions. And so I heard you say that we get an allotment of 5,000 doses per week. And I look on our dashboard for the county and I see it looks like as far back as December 14th, we were receiving allotments, but we've only given out 6,973 first doses. So to me, that's barely more than a week's supply, but you also said we're using the full supply each week. So by my count, we should have received and should have administered much closer to an order of 15 to 20,000 first doses. And I'm not seeing that. So I'm hoping you can help me understand that disconnect.
I can. So we're getting 5,000 doses going forward. Our first allotment was 100 doses. We received shipment of that on December 23rd. So that was our first allotment. There were allotments that went out earlier, but those went to the hospitals. Those went to the hospitals who do hospital workers, and we don't have, we were not part of that. So the second week, and that was the week of New Year's, I believe December either 29th or 30th, I don't remember, we got 2,500 doses. Then last week on Thursday, we got 5,000 doses. And then this week we got 5,000 doses. We've gotten a total, and those are rough numbers. We've gotten a total of about 12,500 doses to date. So when I say that whenever we get supply in, our goal is to then open up clinics and deploy them by the end of the next week. It's because we don't know which day of the week we're going to get supply. We've gotten supply on a Tuesday and a Wednesday and a Thursday. And so for our planning purposes, we have to assume that it's going to come on a Thursday. And then our goal is to, over the next week, get that entire supply out. And we've done that. So last week, we got 5,000 doses. So last week, by Thursday of last week, we had gotten a total of about 7,600 doses. Our goal was to get at least those 7,600 doses out by the end of this week. As of yesterday, we'd already gotten 6,900 doses out. We have 1,000 slots scheduled today. We'll get that out. We got another 5,000 doses this week. I believe we got it Tuesday afternoon. So we have all our clinics set up next week. We will get those 5,000 doses out. So that's how we're scheduling this. We're not behind at all. I know that some counties, particularly the smaller counties, are getting rid of their vaccine in a day or two, and then they're waiting. That's not how we are, and most of the other larger counties are having to do what we're doing, which is pace it out over the course of the week.
Are we giving the vaccines so the vaccines that we got Tuesday of this week, are we waiting until Monday of next week to start giving them, or are we giving them starting day tomorrow over the weekend?
We have clinics going 7 days a week, so there's no waiting. But what we do have to wait for is that we have been told that we will try to get you 5,000 a week. We've requested more actually, but we haven't gotten that. So we don't know the exact number. So 1 week it was 5,100 doses, 1 week it was 4,900 doses. We've been told that our allocation may be cut down to give to other groups. So our challenge is that our supply is not fixed. It's not 5,000 every week for the next few months. It's what we've gotten for the past 2 weeks.
Okay, how many have you asked for?
Ms. Hare, well, after you have other colleagues who have questions, so Fiedler.
I'm actually interested in the answer to Ms. Hare's question. How many of you requested, I think was the answer or question.
Yeah, we had requested 7,500, but given that the state only gets 70,000 or so, I get it. And as we build our partnerships, we can do even more than that. I would say that our throughput probably at this point between ourselves and partners is easily over 7,500. And we're just talking first doses. So built into all our calculations is that there's a second dose that comes due in 3 to 4 weeks. So I'm going to limit everything we say to first doses just for clarity. We're well in excess of 7,500 doses first dose, and we could probably do up to 10,000 to be quite honest at this point if we needed to. We don't see the supply coming to allow that though.
Okay. If I may ask kind of, I think we're in the same realm of questions about quantity. So I watched the Board of Education meeting last night, taking all of this into consideration. How is it estimated that the majority of school system staff will be vaccinated? And it sounds like the next 6 weeks, if I watched and heard correctly last night.
So assuming we get the vaccine, like our vaccine supply doesn't change, we have a plan. We've been talking to the school system about this for weeks at this point. And we've been talking to the fire department as well about this. So our understanding is that there's a particular allotment that's going to be set aside for school system. Once that comes in, and the governor mentioned that yesterday, once that comes in, we're ready to go. So there's really no delay on that once we get it. It'll probably take somewhere around 4 weeks to actually do it because there's 12,000 people in the AACPS system. We haven't seen any group have 100% uptake yet. But that's still a lot of people, and that still would exceed that would take at least 3 weeks of entire vaccine allotment to get through that. So we think it'll probably take 4 weeks to actually get enough vaccine to do that, and maybe longer depending on when we get vaccine.
Okay, thank you. I'll ask other questions later.
Sure. If it's all right, let's see. Let's go with Mr. Volke, Ms. Rodvian, and then back to you, Ms. Hare.
Thank you, Madam Chair. Nathan Volke, District 3. Doctor, I'm curious about the vaccination plan. Within each of the phases, is there a prioritization on individuals who are what I'll call higher risk of death, categories where we're seeing more people have a higher mortality rate, for instance, the 60 plus or even the 70 plus age groupings? So for instance, when you're looking at healthcare workers, is a healthcare worker the same if they're 25 and healthy versus if they're 65 and they have respiratory issues? Or does one move higher on the sort of priority list than the other?
Yeah. So Councilman, there's a couple of different ways to slice that. One is so that's why we've said that we're going to focus on the 75 plus because they are just at a much higher risk of both severe illness and death. it gets complicated within a sector because it takes into account both the person's individual characteristics, but also their job role. And so in your example, it would depend on what they were doing. And that's what's made it actually really hard to do prioritization well, is that there's so many factors to take into account that there isn't really a clean way to do that yet. And I think that's leading to a lot of the kind of reports of people getting it that, you know, others may feel like it wasn't fair, and we're trying to manage all of that.
Mr. Advian?
Thank you, Madam Chair. So I have a couple education related questions or teacher and school staff related questions. So one of the questions that's come up among my colleagues is, if a teacher lives, for example, in Howard County, but they teach in Anne Arundel County, will they be getting their vaccine through AACPS, or and vice versa? If they live in Anne Arundel County, but they teach in Baltimore City, should they expect, I mean, is there coordination between the jurisdictions in terms of like school staff who work, or you get it where you live? Is there, so if anything you can answer on that topic?
So I can tell you that in our county, anybody who's a teacher who is teaching in the county or lives in the county and who teaches in another county is eligible. Our targeted work is to anybody who's teaching in the county. But we will have the opportunity for people who live here and teach in another county to be also vaccinated here. I think that's having all the counties in roughly the same spot is that there's going to be a lot of people in that situation.
Right. On a related theme, I've had the question about teachers in private schools and then teachers in sort of like the non-traditional K-12 setting, like teachers in, for example, a dance studio, or teachers in, I'll give you that example.
So for our purposes, we're talking about K through 12 education.
Okay.
And public or private doesn't matter for our purposes, but it does not include people who are teaching other subjects outside of the K through 12.
Okay. Okay, thank you.
Mm-hmm.
I'm sorry, Madam Chair, did you call me?
I did. Can you hear me now?
Now I can, yes.
Go ahead, Ms. Hare.
Okay, Jessica Hare, District 7. Dr. Kalyana, I actually want to piggyback off of something Councilwoman Rodriguez just asked, because I had a very similar question. Specifically, you may be familiar with the Summit School, which is in District 7, and it's a special education, a tier 1, I think, special education type of school. And I had a question from the executive director there, Dr. McCarthy, about eligibility for the teachers at that school specifically, but then also all non-public schools, because she said that she had heard that teachers in AICPS had already received an email about whether or not they would like to be given the vaccine in the next however many time, and none of the teachers at Summit had received that email. Is it purely a matter of you don't have the Summit School emails, and so if they go on and they pre-register at this PrepMod website that they would then be eligible in the same 1B phase, or is there some sort of stratification that we're not aware of?
There is no stratification. So that thing you were talking about where they were asking, are you interested in the shot or not? That was put out by a CPS to their staff. That's not from us.
Oh, okay.
Yeah, we have been communicating with the private schools, with all the non-public schools, and we'll be sending them out information next week on how to get registered to get vaccinated. So from our standpoint, we're not making a distinction between public and private. We're just vaccinating teachers and staff.
That's super helpful. Thank you so much.
The logistics are different, but not the priority.
Okay, thank you.
Ms. Fiedler.
Thank you, Madam Chair. This is actually, I'm sorry, Amanda Fiedler, District 5. This is a follow-up to Councilman Volke's question, because I did get several questions in this area. So I just want to make sure I understand. So if you have 50, 75-year-olds plus, and you have 50 first responders and you have 30 vaccines available, is it automatic that the 75 plus population gets it? Or do you kind of weigh the individual health of the 75 plus population and the age and circumstances where the group of first responders is working on a daily basis? Both are obviously priority, but I'm just trying to understand how and implemented it works.
Yeah. So this is the reason we have the phases, right? So we had in our phase 1A, we've had the pharmacies working just on their own lane on nursing homes and assisted living facilities. That's why we went through all the first responders, at least the ones who responded initially, to do that. And most of any first responder who wanted to get it is done. If there are more that come up, they'll be added into the pool, but now they're in the pool of phase 1A and 1B at this point, right? Same for healthcare workers. We've moved through a lot of them, but there's still healthcare workers left. So as we expand, that's why we said that we're expanding first with the 75 plus, like as we get into this new risk category, this new phase 1B, they are the highest risk in that group, right? Once we get through a portion of them, and this is where it gets a little hard, I can't give you an exact date because it depends on, particularly with 75 plus and our discussions with aging around issues of registration, web access, phone access, transportation. Some of that is going to determine how quickly we can move through this phase. Allotments of vaccine they get dedicated to the school system, change the metric. If they're allocated to us, then we have to make those determinations. It's really a fluid situation. We are generally making multiple decisions a day on how to change our appointment schedules, tweak them, and then at least weekly, more than that, but at least weekly, figuring out how we're going to allocate for the next week, depending on what happened this week.
Okay. On Ms. Pickard, and then Ms. Schuett, then Mr. Volke, and then Ms. Hare, although she just disappeared from my screen. Hopefully she'll be back by that time. So Ms. Pickard, please go ahead.
Good morning. Thank you, Madam Chair. Thank you, Dr. Kalyana-Raman, for this information. We're getting lots of questions. As I do the rough math, the real issue, it sounds like we're able to staff and do more, schedule more, but the real crux of this is production. The federal government is responsible for the production of vaccine, and then it's being allocated to the states. Is that?
Yes, that's correct.
Okay, so in follow up to that, so do you have information about that increased production? What that is there plans for that at the federal level?
So at the federal level, there's a couple of different things happening. There's a discussion from the Biden administration. We're supposed to actually hear more details on that COVID plan today at some point as to what their intention is to release more vaccine. So there's vaccine that's been produced that is there, and it is being apportioned out with an eye towards keeping the second doses on hand to then deliver when it's their time. The Biden administration is talking about accelerating that release of first doses and having production keep up on the back end. I don't know the numbers behind that because they've not really been made public. So we're waiting to see what that implication is. On top of that, there are other vaccines in the pipeline to hopefully get approved in the coming months, and that would increase our vaccine supply as well. But without knowing the details of the new administration's plan, it's hard to say what, if any, changes in vaccine allotment there would be in the near future.
Ms. Schuett.
Thank you, Madam Chair. Dr. Kay, first of all, I also want to thank you for this presentation and as well as for all of your work in this very hard time. I have two questions. One is, and these are questions that have come from other folks to me. One is, I know of a senior who is 92 years old, but still living at home. I assume she falls into phase 1B, which is being over 75. And so I'd like to, okay, that's correct.
Absolutely.
The other biggest thing I hear everywhere from people locally as well as online is they don't understand how or where to get the vaccine. And I'm taking it from this presentation, I take it that you go to Pre-Mod and that instructs you as to how to register. But I would love to have a link to that if that's available.
So next week that's going to go live and we will distribute that link. So we are developing a pre-registration system. So we're hearing that too, that I don't know how to get information on when it's my turn. And so our pre-registration system will get your information, your contact information, and also tell you what phase you're in and what expected months that falls into. So, try to give people a better sense of timing of what that looks like. And then what that allows us to do is that, when we get to phase 2, let's say, all the people who are eligible in phase 2, we can start emailing them and say, it's your time. Here's how you get an appointment. Because we can't open up appointments going 2 or 3 months out like a doctor's office would, because we don't know how much vaccine we're going to get week to week. So we don't have the ability to open those clinics up yet. That's our biggest challenge right now. So I would say that we'll get you the link next week, Tuesday, most likely, but maybe even sooner. Next week, we're going to have our pre-registration module up, running. Everybody, doesn't matter what phase you're in, everybody can pre-register who wants to.
Thank you very much.
Mr. Volke?
Thank you, Madam Chair. Nathan Volpe, District 3. Doctor, that's actually a great segue to the question I had. So I've had a number of constituents who've reached out to me, some of them who are project managers by trade, some who have, done this, not vaccine distribution, obviously, but project management at government levels and private sector, things like that. The question that I keep getting from them is, if we've known the vaccine's coming for months, we've known that at some point we're going to have to distribute it, and we know that there are going to have to be choices made as to who gets it first, and there's a limited number of doses and all that, why is it that a month into this, we're just sort of getting these things into place, whereas next week now, about 5 weeks after we've had the vaccine, I think, we're going to have this pre-registration. We're trying to figure out who the people are in line. We're trying to talk with Department of Aging and others about who they have so that you ensure it's not just the people with internet access getting this, it's everybody, and you're doing a more equitable distribution. The question I keep getting, and I've got in my email inbox, I'm looking at it right now, about 3 or 4 emails just on this subject about why this wasn't sort of thought through differently. Is there a project manager handling this? Is that something we need to look at getting? Is a project manager to do the vaccine distribution? So I know that's something people are asking me. I'm asking you because I obviously don't have the answer, and I don't know if you have a good answer or not, but I figured I'd pose it and see what you've got.
I mean, this is something that we've thought a lot about. So just to go through the timeline, the priority categories that were, the prioritization scheme that came out was released, I believe, on December 22nd. So that was done very intentionally by the federal government to say, until the vaccine is approved, we can't really tell you who it's approved for, because we need to see the data as to what was in the subgroups. So it was only on December 22nd that we saw actually what the priority groups would be within that. There were a lot of different models, but until the ACIP, so that's the Advisory Committee on Immunization Practices, decides that, not much we can do. And in fact, they do this for every vaccine. And we follow that. And we and everybody in the country follows what the ACIP says. So that's the prioritization issue. In terms of infrastructure, I can just tell you on a human level, getting our first dose on December 23rd is a hard thing to do for a department and for an entire sector that's been under the gun for 10 months. So it's just a perfect storm to deliver vaccines the week of Christmas. That's the human, honest truth of it. And then the other piece of that is that we haven't gotten any money to do any of this work. We have been pulling people. I know that I have chunks of my staff who haven't had a day off in a month to do this work. We haven't gotten a single dollar to stand any of this up. So, there's been I'm just going to be blunt, there's been very little to no support from the federal government in terms of any financial assistance to do this work. And it wasn't until the last week of December that we even knew we could carry over CARES dollars, right? These are the sort of things that make it impossible to plan and make it impossible to think out. And then you add on top of that we're in the middle of a surge that we've been talking about. It's been pulling more people into contact tracing and testing. I don't know how I can be honest with you and tell you that I am just amazed at what our staff have done to pull from a middle of a surge to do a vaccination effort. So from a project management standpoint, I wouldn't have designed it this way either, but these are the tools we've been given. And you see that every county in Maryland has to figure this out. The state has decided to give counties the latitude, but that also means that we all independently have to develop the same system, county by county by county.
Mr. Volke, is your question a follow-up?
Very brief follow-up.
Okay, go ahead.
Doctor, question about the CARES funding. I know you said it got extended, but is the county able to use CARES funding for the vaccine rollout? I know you've had to use it primarily for COVID-related purposes. This seems like that would fall under there. So just curious, is that money that's available to the health department to hire the staff and do the things you're talking about?
Yes, it is. And I'll add that with the new package put out by the new package that was put into law by the federal government, there will be funding coming for vaccinations. But
thank you.
Right, yeah.
Ms. Hare.
Thank you very much, Madam Chair. Jessica Hare, District 7. On this PrepMod website, I'm just thinking about people's data, and sometimes people don't like to really share their data with a pre-registration type of thing. Are you going to be required to pre-register in order to sign up for a vaccine later, or will people be able to separately access the website to just sign up for an open slot if they say check the website every day? And then piggybacking on that, who's maintaining this data? Is it the Department of Health under HIPAA regulations, or is it, Anne Arundel County, type of thing?
So there's two systems. One is the pre-registration system that's being handled at county level, and then the second is PrepMod, which is actually handled at the state level and it's HIPAA compliant. So the pre-registration is just a way for us to get names and contact information for people, and then once it's done, we're done with it. We're not keeping it forever. And we're actually structuring it so that it does not have protected health information. It's a communication tool. The second is PrepMod, which as I mentioned, is a tool that the state and other states use as well. It's one of a couple of different vaccination appointment and management systems that exist. That's HIPAA compliant, that's managed by the state, we're part of it. And right now, that's how we're registering people. We're required to provide that. It's like any other health visit. We're required to put some information in. If you don't want to put it in PrepMod, we're going to have to put it in PrepMod. So somebody's going to put it in PrepMod.
But you're not required to pre-register.
You're not required to pre-register, but we're really encouraging that because it's going to make this process easier. The biggest challenge that we're having right now is that even when we send out links to appointments to healthcare workers, we're getting children, neighbors registering, and it's causing problems, right? Like we hear the stories of, well, that person shouldn't have gotten it. And so that onus falls on us at the health department to make sure that we're adhering to the phase that we're in. So we're trying to manage that data. We know that if we put out appointments out there and tell everybody just be good and sign up for your phase, that's just not going to work. That's not how it's going to happen. And so we're trying to balance this issue of really maintaining that prioritization so that we're getting to the people who are in the phase while trying to be as streamlined as possible. If there's other ideas on how to kind of hit that balance, we're open to it, but that's where we are now.
Thank you, Dr. K. I do want to interject that Chris Trumbauer, the budget officer, and is available to answer questions about CARES funding, vaccination funding. I think if we can, it would be best to kind of stick to questions directly about vaccinations, and separately, we do have time to ask Mr. Trumbauer that, but for now, since Dr. King is quite limited. We otherwise wouldn't get to hear from him until next Thursday or something. So I hope we can focus on those first, if you don't mind. Ms. Fiedler, you're next, and then Ms. Rodvian.
Thank you, Madam Chair. Amanda Fiedler, District 5. So I have a few questions from constituents. The first is, does the vaccine, once you get it, last for a lifetime?
We don't know the answer to that question. We believe it will last for a number of years, but it just hasn't been out long enough to answer whether it's going to be a seasonal vaccine like the once a year with the flu, or if it'll have a longer lifespan than that.
Thank you. And if I may just ask one more question, I have a whole list that we can do two at a time. But I noticed that a constituent reached out as an attorney in the county and said that the attorneys were at first in phase 1C, but have now moved to phase 2. Is that because we took the CDC recommendations first, and then when Maryland Department of Health came out with their recommendations, it was to move the attorney arena to phase 2, or was there another reason?
Nope, that's it.
Thank you.
Based on the MDH guidance.
Ms. Rodvian.
Sorry, I had to unmute myself. Thank you, Madam Chair. Lisa Rodvian, District 6. So my question is, so starting next week, there's going to be the website where people can go to pre-register, and then they will be contacted to get an appointment when it's, when we reached their phase. Will that include, I just want to make sure that I'm understanding. I know at the beginning, when we were looking at congregated living settings, for example, folks, that was being done sort of organizationally, like organization by organization. Does that mean, for example, I'm again stuck in the teachers because that's where where my day is. Will teachers be using that same pre-registration, or will they be addressed organizationally? So I'm basically asking, do they need to go through that process, or will they be addressed through AACPS and other organizations that are in a similar position that, their whole employee group would fall into into one of the phases?
So we'll still be going through organizations as much as we can, but what we found out with our healthcare workers is that we just miss a portion of people when we do it that way. So we want to provide another mechanism for people to say, hey, I'm a X teacher, nurse, whatever the case may be, and we can pick them up that way also.
So like private school K through 12 teachers would, they might hear from their organization if the health department is able to reach them that way. But if for somehow maybe folks that live here but teach in another county that wouldn't be captured by an organization in the county, they could use the pre-registration site and still access their vaccine through that, through their membership of that category.
Exactly. And the other piece to that is that when we reach out to an organization, we're reaching out to 2 or 3 people at that organization to distribute within their membership.
Right.
And what we also found with the healthcare workers is that timing and communication wasn't always clear. And so some of the people in that, in that practice might not know and say, hey, you didn't get in touch with us, but we're reaching out to 300 people who are then reaching out to 30,000 people. So there's that, but that's how we have to do it from an organizational level.
Madam Chair, may I ask a second question while it's still my turn?
Unless you have to go, do you
I have about 10 minutes left before I have to go.
Please go ahead and then move on.
So this is something that is probably going to impact multiple organizations. Again, this is relating back to AACPS, but surely will impact other groups. So we're understanding that when people receive the second dose in particular, they're more likely to experience the sort of adverse or side effects of the vaccine. Are there sort of plans in place to address the staffing repercussions of having, obviously it's not everyone, people are going to respond differently, but are there plans in place to address those staffing repercussions? Or I unfortunately could not watch the BOE meeting last night, so I don't know if that was part of the conversation last night, or if that conversation has been had with the Board of Ed and other entities that would be similarly impacted, because obviously if someone is having really severe side effects or has a fever, then, that's going to cause a staffing issue.
Yeah, so that's definitely a conversation that we've had with every organization that we talk to, is to recognize that you need to stagger it out. With somebody with the large category or a large employer, you're going to have to, right? Like just in terms of volume of people. So probably even more critical, and for small organizations or small sectors, to know that judiciary is a good example. We told them they have to stagger it out over the course of a week, so that they don't all get sick on the same day if they get it vaccinated.
Right.
So that's a part of our guidance.
Okay. Thank you very much. Just wanted to know that was, you cover everything.
Ms. Hare.
Thank you, Madam Chair. Jessica Hare, District 7. Dr. Kalyana, on the slide where you showed the locations of the clinics where people can get it, I did not see anything south of Annapolis, and I understand you said you're going to be expanding. When can we expect a site south of Annapolis?
So by the end of this month, we should have our 4 large vaccination sites. The furthest south would be the Navy Stadium. We'll have our mobile stood up. That'll start going out, and that will definitely be going down to the South County. And then we'll need to talk, once we get our mass vaccination clinics up and running, then we can pivot to smaller sites. So expect more discussion about this in February as to sites down in South County.
Okay, even something, Riva, Edgewater, something, because that's a huge geographic area for everyone to try and come to Annapolis. And as we saw with some of the COVID testing sites, it creates massive kind of log jams. I recognize you're working with some constraints in terms of staffing and the number of doses, but certainly from an infrastructure standpoint, it would be awesome to get something a little sooner, a little farther south geographically.
Mm-hmm. I hear you.
Ms. Fiedler.
Thank you, Madam Chair. Amanda Fiedler, District 5. Dr. K, I have some very specific vaccine and COVID kind of intermingled questions. I have 5 of them. I don't know how you want to work this, Madam Chair, but I'll go with the first one. If someone has COVID-19, how long do they have to wait before receiving the vaccine?
We generally recommend waiting 90 days because you do have some level of immunity, immediately after getting it. So our general recommendation is you can wait 90 days before getting it.
Okay. And Amanda Fiedler, District 5, if you have been exposed but you aren't positive, do you have to wait to get the vaccine beyond just the quarantine period?
You should wait for the quarantine period. You don't want to get vaccinated at the same time that you're potentially going to convert to positive. If you know that, obviously some small number of people will inadvertently do that, but if you can at least wait a few days, and that quarantine period is 7 to 10 days at this point, so we recommend waiting.
Okay, and if, Amanda Fiedler, District 5, if you get COVID-19 after the first injection, what should you do?
If you get COVID-19 and that it's the same, there's nothing different to be done. If you get those symptoms, you should still get tested. You'd still go through the through the isolation and contact tracing and quarantine process. So nothing changes if you get COVID-19 and you've been vaccinated.
But you shouldn't delay, I'm sorry, Amanda Fiedler, District 5, you shouldn't delay that second vaccine. There's enough time between the two where it would be safe to go back as scheduled for the second vaccine?
Oh, okay, I see the question. Sorry, I didn't understand exactly what you were getting at. In that instance, you should discuss it with either us or your healthcare provider as to the timing of that second dose.
Okay. And then Amanda Fiedler, District 5, after getting both doses of the vaccine, what is the time period between that second dose and when you are at the 95% effective coverage for COVID?
I don't know that there's a date on that. What we see with the first dose is that it takes about 1.5 to 2 weeks to really start seeing the effect of that. In terms of the effectiveness, I believe this was at the 3-month mark that it was being determined. So I don't know the exact time in which it becomes 95%.
Okay, thank you, Amanda.
Number for that.
Okay. That makes sense. I know we're very early on in this, obviously. Madam Chair, one more question, if I may.
Okay.
All right. Is there, Amanda Fiedler, District 5, is there going to be at some point in time, and if you know that point in time, what is it, that there is one single dose vaccine versus the 2-phase?
So there are some vaccines that are 1 dose that are in trials right now, but as to when they get approved, I couldn't tell you that. It depends on how those trials go.
Okay, thank you.
Ms. Pickard.
Thank you, Madam Chair. I have one question because I actually know the answer, but I think it's important to have it answered here regarding what it actually means to be vaccinated for COVID-19, because I think there is still some misinformation that you're now superhuman, but you can still get COVID-19 and you can still spread it even though you're vaccinated. The vaccine, it's my understanding, protects you from the most severe symptoms. Can you confirm that for me and maybe speak more intelligently about that?
So what do we mean by efficacy? So 95% efficacy means that it caused a 95% reduction in either the development or the severity of symptoms of COVID. And so it doesn't mean that you won't get it. It means that if you do get it, it's going to be extremely mild or it'll be less severe than it was. And so that's why we say that you still need to wear your mask, particularly at this point. Mask distancing, even if you got the vaccine, is because there's nothing that says that you couldn't spread it to somebody else. It just means that you will be in much better shape if you get it, but you still potentially can spread it to others. And because we just don't have enough vaccine yet, we're still not in a place where others can necessarily take getting COVID. So that's why we say, please keep masking, distancing, avoiding gatherings at this point.
Thank you, Ms. Allison Pickard, D2. Thank you for that. I just wanted to include that in the conversation today. And then the only other thing I have, this has been extremely informative, and I appreciate you taking time out of your very busy day. But I also want to extend my sincere gratitude to you and your health department for just getting us where we are today. This has been incredibly challenging at the local level with the lack of coordination at the federal and at times the state level. So I just want you and your staff to know that I am extremely grateful to the hard, incredibly challenging work that's been happening over the last 10 months. Thank you.
Mr. Volkey.
Thank you, Madam Chair. Nathan Volkey, District 3. Doctor, I just want to make sure I understand the way the rollout is going in case I get questions from people. So in the slides that you presented, you showed all the phases, and further down you talked about how many vaccines the county gets on a weekly basis. I think you said 5,000. And then in the next slide, it talks about the state allocations of the vaccine, 58% going to hospitals, 25% to local departments of health, 13% for the nursing homes, to CVS and Walgreens. So when we're looking at the phases, does that mean that you're not vaccinating, the health department is not vaccinating any of the healthcare workers or any of the nursing homes? So all the vaccines that you have are then being concentrated in the other categories under those phases?
So the breakdown, the 58%, 25, 13, that is to date, and that's going to change.
Okay.
Some of those groups are more ring fenced than others. So the nursing homes, assisted living facilities, those are entirely within the domain of the CVS Walgreens. In terms of hospitals and the health department and other providers, that's a more fluid situation. So just yesterday we had conversations with the hospitals to start with healthcare workers not in their system. Just they have vaccine and we're trying to figure out these allocations. So, if you ask me next week, I'm going to give you a slightly different answer based on what happened this week. So I would take all of these allocations as a point in time understanding.
Okay, thank you. Yeah, Nathan Volkey, District 3. I guess my follow-up what I'm asking about is, I just want to try to figure out, okay, if we've got this many firefighters and this many EMTs and this many police officers, we've got 5,000 vaccines, is how quickly we think we get through vaccinating them. Then we move on to the judiciary and then corrections and then all these. And then that gives us a sense of when we think we might be able to vaccinate the highest risk population that it seems like we have, which is really people with the pre-existing conditions or those who are in the older age bracket. And I'm just trying to get a sense of when we might hit that point, because to me, once you hit that, your death rate is going to start to drop pretty significantly if you're able to blunt the worst edges of what this is doing to particularly the most vulnerable populations. So that's what I'm trying to, in my mind, figure out. If you have a sense of, you may not even have that projection yet. I get that. I'm just trying to figure that out. At 5,000 the next month, if it jumps up to 10, my quick math is you're probably looking at about 60,000 people in this county who fall into that 70 and up age bracket based on some demographic data I could find. So, doing that rough math, maybe we're 6 to 8 weeks, and then we've got all those people vaccinated if the pace of 10,000 a week comes out in terms of vaccines. That's just what I'm getting at and trying to understand.
So I can give you a rough for phase 1B. So your numbers are probably right for the 70 plus. So we're looking at the 75 plus. It's about 40,000 or so. It's a rough number. And then we factor in roughly another 20,000 for schools and childcare. So that's about 60,000 people. We don't see 100% uptake, but let's just project 100% uptake at these current supply levels. That's 12 weeks. Assuming a really high uptake level of 75%, that's still 9 weeks. That's a couple of months out. And we still have residuals from phase 1A, residuals we haven't gotten to yet. So healthcare workers who are still coming into the pipeline, and then others who will convert from let me see to I'm now ready. So we're thinking that it's going to take us a couple of months unless we get increased vaccine supply.
Thank you.
Ms. Hare.
Thank you, Madam Chair. Jessica Hare, District 7. Dr. Kalyan-Raman, I'm going to apologize in advance for sort of the very broad nature of this question, but it sort of dovetails off of what Councilman Volke was just saying, and it ties in a little bit of a discussion that we had at our work session earlier this week about sort of what are we looking for in terms of health metrics and things like that for not just for the reopenings and things, but sort of the state of emergency in the county to end, and what is it we're working towards? Having a goal, I think it was Councilwoman Lacey who said that having a goal that we're working towards might actually help the general population kind of see the light at the end of the tunnel in a way that's been a little bit hard these last couple of months. So knowing that we're in phase 1A, that you're looking at phase 1B, how many months? You just said 12 weeks, I think, if you had 9 weeks for 75% uptake of the next 60,000 people or so. What are we looking for in a combination of, is it a death rate, case rate, number of people vaccinated? What are we working towards to kind of get to the next step as a county and as a population?
So I think I'm going to answer broadly, and then I have a couple of questions because I think it matters what we're trying to do with it. So
okay.
We're just talking at a very general level of what's happening in our county. It's the same metrics that we're looking at. We're looking at our case rate, our hospitalizations, our capacity. We're looking at our positivity and our death rates to help calibrate that. We're looking at, are we increasing or decreasing? All of those metrics are really the same. The vaccinations will, based on how we are doing that, right? As we start to get uptake as we start to get it into the 75 plus, we should see it affecting our death rates. We should see that come down. We'll see if because it's such a vulnerable population, we'll see how it affects the hospitalizations, right? As we get deeper into this, the more and more people we get vaccinated, the more that will help mitigate our hospitalizations. And that's really, that's the key driver, because if we overwhelm our hospitals, there's nothing to back it up. There's nowhere to go with that. And so as we get more of this out, we'll be able to see how are those metrics affected. It's going to be mixed in with springtime. Means a couple of things. People can go outside, and that is the tail end of cold and flu season. And so we expect the effectiveness of this virus itself to go down a little bit during springtime. Just the same way as we had it, effectiveness increased in the fall. So there's a couple of good things coming up in March in terms of like I said, end of cold and flu season and people getting outside and more vaccinations. So the metrics themselves are the same metrics, but the vaccines will affect how they are developing.
Okay, but assuming the metrics are, I mean, we're never going to get to zero. That's not, so what are we trying to get to? What in order to move to the next, what is it that you're looking for to say the state of emergency in your mind from a health perspective is gone?
Yeah, so our push-pull is this. When do we reach a point where we can, I can't speak to the state of emergency piece. That has more to do with executive powers and all that. I can tell you what I'm looking at from a public health standpoint is that we have these restrictions in place, we have these precautions in place, and our big challenge is that whenever we're doing well, if we loosen them up, we're going to rebound. The vaccine is going to change that dynamic. It allows us to loosen up without seeing the rebound. That's the point of it. And I think a good way to think about it is flu. Well, this is not the flu, right? In terms of how it affects the body, in terms of how it spreads throughout a population, it has large similarities. And we have flu deaths over the course of winter. It's not happening this winter for all the reasons that we're doing these things now, but we see some number of flu deaths. We see flu hospitalizations. We push out vaccine. But the idea is that once vaccine is available, we're not doing all of this stuff because vaccine is available. And then we from a public health standpoint are just going to keep pushing everybody, please get your COVID vaccine, right? But you won't need to do all these other restrictions because there's a different tool available at an individual level to help you. So I think that it's challenging because there's so little vaccine at this point. It's going to take a time for that effect to build up. That's our problem, right? Like if we're really only doing 1% of the population each week, because that's all we get in vaccine, it's going to take a while for the effect to build up.
I understand that, and I don't mean to push, but again, trying to give people something to look for. Is it that, okay, let's say in the springtime it's a little bit warmer, it's the end of flu season in general, maybe you relax some restrictions and there's not a rebound. That's what you're looking for? Or is it when you've reached 85% of the population's been vaccinated, that's what you're looking for? What's the goal before, and I realize you can't say with the state of emergency, but everyone in their mind, that's where people are thinking.
So our hard target is somewhere between 60 and 80% of the population getting vaccinated. Somewhere in there, you'll get your population immunity.
Okay, thank you.
Right? But you'll see effects well before that.
Okay.
The thing is, I don't know when you're going to see those effects.
Okay.
To alter the dynamics of how we've structured everything right now. And I think that's the hard part. I haven't seen anything that has a great answer for being able to project that.
Okay, that was helpful. Thank you so much.
Dr. K, I have a couple of questions. This is Sarah Lacey, district. The first question is for people who are in a population that's maybe not recommending vaccine, say you have a pre-existing lung condition or something where it's just too risky. Do you think there would come a point where it becomes much less risky for kind of condition to be able to get the vaccine because the community spread is much lower? We've gotten somewhere in that 60 to 80%, and so they're just maybe less likely to actually contract the virus, overall. Does that change for that population of people?
Yeah, generally there really aren't any conditions where it's not recommended to get it. If you have any concerns, we always suggest you speak to your doctor about them. To see in most cases, if you have a higher risk condition, it's actually more important that you get it. But like I said, always a good idea to talk to your doctor about that.
Okay. My other question is, are you aware of whether so far have we had to waste any dose of vaccine? And, if so, can you tell us tell us about it, and hopefully we have some kind of avoiding wasting doses of vaccine or auditing
Yeah.
to ensure that we haven't.
Yeah, to my knowledge, we haven't. And I've asked about this, my staff. In terms of handling it, the Pfizer doses come in Pfizer vaccines come in 5-dose vials. Moderna comes in 10-dose vials, and because of the way they work, and once you take the Pfizer out, you have to use it that day. So we have a pretty elaborate process to try to figure out how much vaccine we need that day, and then towards the end of the day, we start pulling out fewer and fewer vials and thawing them out, and trying to really calibrate how many doses we draw up. We also have a way to use up those last few doses, particularly in our morning vaccine clinics. If we don't use up those doses, they just get carried over to the afternoon site. So we have systems in place to not waste doses. And then as we grow, we'll continue to keep doing that, but we will also, honestly, we may vaccinate a couple of people out of phase just so we don't waste a dose. We try to count really tightly, but if I've got 3 people in a 5-dose vial, I'm going to find 2 extra people to vaccinate them. So you're going to hear stories. Somebody got lucky at the end of the day. I don't know what to say. That's better than
here. Does anyone else have any more questions for Dr. K? Because if not, we'll minutes with Mr. Trumbauer. Mr. Volke, go ahead.
Thank you, Madam Chair. Nathan Volke. Just quick question, Doctor. I think you answered this, but it's the question that I do keep getting a lot from constituents. Once you get that pre-registration system set up, how will you be pushing that information out? How will people know how to log in and register? I've gotten a lot of people 65, 70 years old emailing me saying, I'm going on the health website, on the county's website. I can't find where to sign up. I want to sign up to get in line. So how are you going to distribute that information? What's that going to look like? And you said it would be next week. So I want to just get people what's coming.
We're gonna push that information out across every channel we have. We'll publicize it through our partners, through media. We'll talk about it with the newspaper, just pretty much every way we can. And I think the good part of that is that because it's a one-site pre-registration, we can use that same information for the next few months, right? You never have to think about it. Just go to that spot. So we'll have much more next week on that.
Ms. Hare?
Thank you, Madam Chair. Jessica Hare, District 7. I actually just had a constituent email me right now who is watching and specifically asked if this whole presentation will be posted, this whole briefing will be posted online. And I assume the answer is yes, it's going to go where all of the other council briefings go, but I just wanted to double check.
We'll post it on our website. I don't know about that.
Okay, you'll have it. Okay. All right. Thank you.
Ms. Fiedler?
Thank you, Madam Chair. Amanda Fiedler, District 5. I too just had a quick question pop up. There's been news coverage of lines wrapped around buildings for the vaccine. Can I assume with this registration process that will be avoided? It will be scheduled so that we don't have that type of situation?
That's exactly why we're doing this.
Okay.
We don't have the weather for that, for one, right? And I'm informed that our video from this morning will be posted also. Normally have meeting videos posted so people will be able to access the presentation just by watching the video from today. Any answers for Kay? I think he'll hang around for a couple more minutes, but if you'd like to join us, I'd be happy to recognize you to respond to the CARES Act funding question.
Thank you, Madam Chair. Chris Trumbauer, County Budget Officer. Just want to add a little bit of context to Dr. Kalyan-Araman's answer about the CARES funds. We certainly are able to use the remaining CARES funds on our vaccine effort. I just want to caution the council that of the funds that are unspent, almost all of them are already earmarked for ongoing programs. So we haven't gotten any new CARES funding, remember, we just got the deadline extended. So I just wanted to make sure that we all realized that is an acceptable use for them, but we didn't get any extra money. So if we spent that on vaccines, we'd need to find other funds to spend on the ongoing other programs. And most of the remaining funds are already directed towards the health department in their other programs like PPE and staffing and contact tracing. So just wanted to make that clarification.
Does Mr. Volkey?
Thank you, Madam Chair. Nathan Volkey, District 3. Mr. Trumbauer, I guess, so this kind of gets to the question that I was asking the health officer about earlier. Constituents have been emailing me asking about who's been planning all this, right? Project management, who's been putting this together. And I understand, like Dr. Kalyan said, that it's kind of, they're doing it as they're going, but we've also known this was coming. So I guess, is there any sense of we should have kept some money back knowing that we would need it for vaccine distribution? Is there another pot of money we can look to, like the CAO contingency fund to pool if the health officer needs more money for this? What's the plan in terms of if his department needs more money to get these vaccines out? Is there money in the county somewhere that we can pool from to use for that purpose? That's what I'd like to know if it's there. If it's not, then I guess that's what it is.
Sure. Thank you. Thank you, Councilman. Chris Trumbauer, Budget Officer. Yes, vaccinations are certainly a priority, and we will find a way to deliver funding to the Department of Health as they need it. We can pull from other sources, fund balance, or like you mentioned, the CAO contingency fund. We are hopeful that there will be an additional federal bill that will provide some local government assistance directly for the vaccine effort. And then we'll also monitor to see what, our friends in the General Assembly are in session now, and you never know what they're going to do. So we can see if that's a possibility. But we're not going to not support vaccines because we don't have CARES funding for it. We will find a way to fund it. My only point that I was adding some context to is that we don't have a pot that's unappropriated ready to go to vaccines, but that is part of the reason, council member, that we did not spend it all by December 30th, because we did want to hold some in reserve for ongoing efforts and also have some flexibility with regard to vaccination support.
Thank you.
Do my colleagues, Ms. Pickard, go ahead.
Good morning. Thank you again, Madam Chair. Allison Pickard, D2. Thank you, Mr. Trumbauer, for being here this morning. I was trying to go through my note from, I have spent a lot of time this week with various levels of government. Both Senator Cardin and Senator Van Hollen spoke about the newly passed legislation, and while there was not funding directly to local governments, I can't find the slide if there is going to be funding out of the federal, the second relief bill to states to help roll out vaccinations, which could trickle down to Anne Arundel County. I don't want to put you on the spot about federal dollars, but I don't recall from that. I can't find my slides at my fingertips here.
Chris Trumbauer, Budget Officer. So I think, Council Member, you're asking if there's any direct funding from the bill that passed at the end of last year. There is direct funding for specific programs. So, for instance, the eviction prevention program, which we run through ACDS, they are getting a direct allotment. There's very specific things that they have to do to be able to spend that money, and I think you all would agree Kathy Koch is a tremendous professional and will jump through whatever hoops are necessary. But there was, to my knowledge, there was no general funding support for us to devote how we wanted to. There were just some specific programmatic elements that got funding, similar to a restricted grant.
Okay, so that's probably why I can't find the slide that says vaccination funding for anybody in my federal information. So hopefully that'll be coming soon.
Madam Chair.
Mr. Barron.
And I'm happy to provide the slides that the senator used last Tuesday. For vaccines, there was 30 billion in the recent bill, and they estimated 75 million would go to the states for vaccines. I am not sure what the restrictions will be on that. And it's my understanding that none of that money comes directly to counties. It flows to the Maryland Department of Health, and where it goes from there is a state decision.
Okay, well, it is 11:30, the time we're scheduled. I think everyone had excellent questions and a diversity of questions. I don't see us waving a flag and saying, please, I have one last question. So thank you all for joining us this morning, especially to Dr. And I thank you. I think the entire council thanks you for all that you're doing and leading the health department and all and folks who've been working incredible amounts of overtime to keep the county safe. So thank you. I will see you all, my colleagues, on Tuesday evening at 6 p.m. Take care.